3. Good evening, everyone. I'm glad to introduce this congenital heart disease course, actually presented and prepared and streamed by the Cardiology Education channel. This congenital heart disease course is a big course, actually. It includes 14 webinars covering all the aspects of the basic congenital heart disease, all what you need to know for the basics of congenital heart disease, and also some of the points regarding the advanced part, special discussions regarding the pathophysiologies, special discussion regarding how to treat the principles of surgeries. Actually, this is not a one person or just even a board of CEC effort. This is the effort of a very big team joining people from everywhere. We have friends from Egypt, we have friends from Ain Shams University, from Cairo University, we have friends from Aswan Heart Center, we have international friends, we have friends and collaborations from the EAC, and the Italian cardiologists of tomorrow are also represented with us. I speak about myself, and I would like to thank the CEC co-founders with me, Dr. Karim Mahmoud from Cairo University, Dr. Haitham Suleiman from Fayoum University, Dr. Abdurrahman Gamal from National Heart Institute, and Dr. Ahmed Saeed from Shibin Qom Teaching Hospital. I would like to thank all the contributors to this course: Ahmed Osman from Aswan Heart Center, Muhammad Sabir from Ain Shams University, Sarah Musteli from Italy, Genova University, Abla Ali from Ain Shams University, Amira Noor from Ain Shams University, Dina Adel from Ain Shams University, Hatem Hosni from Aswan Heart Center, Heba Kamil from Ain Shams University, Khalid Shams from Helwan University, Mahmoud Shahata from Aswan Heart Center, Soha Rumeh from Aswan Heart Center, Yasser Siddi from Aswan Heart Center, Yasmin Abdelrazik from Ain Shams University, and Yusuf Amin from Ain Shams University. As you know, and as we work here at CEC, our rules are pure high-quality science. As you see, we are only driven by passion. We are driven by love to teach and love to learn, actually. So we are teaching and we are learning at the same time. We are exchanging experiences with everyone, and we are moving forward towards the better. This will not be achieved except by everyone's help and contribution. So everyone attending and watching us, you are part of our team, you are part of CEC. One day you can be a speaker or a moderator here, so long as you fulfill the standards of this channel. Today, I would like to launch the first webinar. The first webinar in the course will be discussing the approach to a patient with congenital heart disease, and the second part will be the pathophysiology of left to right shunts. I'm glad and honored to present a panel of distinguished speakers and moderators. The first part will be spoken by my dear friend, colleague, and co-founder of CEC, Dr. Haitham Suleiman Gharib, lecturer of cardiology at Fayoum University. This will be followed by the second half of the webinar, the pathophysiology of left to right shunts, and gladly enough, it will be presented by a surgeon. So we understand hemodynamics and how the surgeon thinks, and this will show you the rationale later on in the treatment. I would like to introduce Dr. Hatem Hosni, FRCS, FEBCTS cardiac, and FEBCTS congenital. He is a consultant cardiac surgeon at Aswan Heart Center and one of the best in Egypt. This would not be possible without having a very proper scientific moderation, moderated by my dear friend Sarah Musteli from Italy. She's currently attending a fellowship of congenital heart disease at University of Genova in Italy. She is a board member of the Italian Cardiologist of Tomorrow, and she was also elected as the Vice Secretary of EAC, International Young Academy of Cardiology, with whom we are doing lots of collaborations, and you will see that in the upcoming projects. This moderation will be also co-moderated by my dear friend, colleague, and brother, Dr. Khalid Shams. He obtained his PhD in the field of congenital heart diseases and pediatric cardiology from Ain Shams University, and now he is working as a lecturer of cardiology at Helwan University. I hope this is not a very long introduction. I will leave the mic now to my dear friend and colleague, Dr. Sarah Muscatelli, and Sarah will start introducing the first speaker. So go on, Sarah, please.
Thank you very much, Dr. Zara, for your introduction and also for the possibility to be here and to be involved in this congenital heart disease course. It's my pleasure to introduce Professor Haytham Soliman from the University of Iran in Egypt. He is one of the co-founder of the Cardiology Educational Channel, and he's gonna give a lecture on approach to congenital heart disease.
Thank you, dear Sarah. It's a privilege and honor to be part of this education channel and this webinar. We will talk about the approach to congenital heart disease, which I'll try to break the ice in the field of congenital heart disease for our audience. And I would like to start right away. So congenital heart disease or congenital heart anomalies are defects in the structure and, of the heart and great vessels which are present at birth. And congenital heart disease are the leading cause of birth defect related deaths. And to figure out what's the problem of the congenital heart disease is seldomly asymptomatic in most of the cases. And symptoms, especially in newborns and in infants, are always misleading. Signs are not always clear, and investigations are difficult, especially in the newborns and in infants. Despite that, every congenital heart disease has a little prevalence in per 1,000 live births, but these diseases are more common than you think. And unlike the configuration or unlike the concept of most of us, the VSDs have the most privilege among the congenital heart disease cases. Congenital heart disease children have many problems. They do present with more difficult presentations than cardiac patients and than infants without congenital heart disease, like graft failure, like pneumonia, meningitis. They tend to have higher mortality, higher rate of admission, and higher rate of chronic conditions and complexity. And they tend to return to the hospital more. One other aspect that congenital heart disease beats us in one stage in heart failure. You know that heart failure begins with stage A, that this is the patient at risk of heart failure without any structural heart disease. But unfortunately, in congenital heart disease patient, this patient is stage B from the start, from its birth. So the progression of heart failure and the progression of the disease is more vigorous, and it comes rapidly. One bright side, that if we treat these congenital heart defects at the proper time, they will have an excellent survival, even when they grow old till the age of 30 years or 40 years. Mind you that any defects apart from single ventricle have a survival rate of 86%, 90%, 97% if they are treated properly. So we have to screen these patients thoroughly in order to give them a chance to survive more. So that's why we need a low clinical threshold of the suspicion of congenital heart disease, more investigations, and more rapid treatment. So we need to check their hearts. And how we can do that? By having proper history, taking care of the slight symptoms and signs they have a basic ECG and examination, have an X-rays, echocardiography, CT and MRIs, and of course, cardiac catheterization with hemodynamic monitoring. And we must know and teach the parents about the treatment option they have. Usually in the field of infancy and newborns, the surgical intervention is the gold standard treatment. Otherwise, there are many defects now that are treated with cardiac catheterization, proper medication, healthy food,
Hello. We are having some connection problems with Hytham, but we'll try to recuperate him.
What happened with Haytham? He was disconnected?
I think Zahran, it's a connection problem all over Egypt. Also, my PC was disconnected.
Yeah. So being that, so I thought it was only me. No problem. No problem. When
Yeah, I
Haytham is
think all over
connected,
Egypt.
start where he stopped.
Was also, I think it's a Zoom problem rather than a connection problem.
Okay.
No problem. We're going on. Okay, Khalid and Sarah, please discuss the few slides that Haytham.
Still, we are live on YouTube.
Yeah, go on.
Good afternoon, everyone, or good morning, wherever you are all over the world. First of all, congratulations to the whole CEC team for the launching of this series of congenital heart disease webinars. I would like to thank my dear colleague and friend, Dr. Mohammed Zahran, for creating this marvelous idea of doing congenital heart disease webinars. And it's my pleasure to share moderating this session with Dr. Sarah. Until Haytham is back to us.
Yeah, I came back again.
Okay, welcome.
Okay, continue, Haytham, your
I
slide.
think that we
Okay.
don't have problems. We can continue with this presentation. So we will wait for your slides.
Okay. So when did I lost connection? At this point, or?
Actually, you were talking about the.
You can start one slide earlier, Haitham, please.
Yes.
This one? Okay.
Yes, please. Yes, please. From the beginning of this slide.
Okay. So we must know and learn how to treat congenital heart disease patients and what are our options, and learn this to the parents also. So in the infants and newborn, we have the option of surgery, which is the gold standard in this age. The cardiac catheterization and its intervention is emerging now and is taking a lot of indication in the field of congenital heart disease. We must keep our mind about the proper medications doses, especially in infants and newborns, healthy diet, vaccination, which is very, very important, especially pneumo vaccine and influenza vaccine, and a proper schedule for follow-up of these patients. Also, we know to teach ourselves and the parents and the patients about the consequences of not treating congenital heart disease and the complications of congenital heart disease, like heart failure, arrhythmia, pulmonary hypertension and Eisenmenger syndrome, the thromboembolism, venous or arterial, and strokes. We must also know and teach our patient what are the contraindications in their activity, like competitive sports, like some medications, like pregnancy, especially in cyanotic females, and like some sports like climbing high altitudes in some patients. So now we are coming to the simple classification of congenital heart disease patients, which is cyanotic and acyanotic patients. And acyanotic patients and cyanotic patients are also classified by the degree of pulmonary blood flow. If the patient is acyanotic with an increased pulmonary blood flow, this will be the category of atrial septal defect, ventricular septal defect, patent ductus arteriosus, and AV canal. If these acyanotic patients has an obstruction in the blood flow, they might have coarctation of the aorta, aortic stenosis, or pulmonary stenosis. On the other hand, cyanotic patients have a degree of decreased pulmonary blood flow, like tetralogy of Fallot or tricuspid atresia, or complete mixture of the blood flow, like transposition of great arteries or the total anomalous pulmonary venous return. We are aiming in this course that we build your information and able to have in mind this complicated classification that we will not tackle today, but we hope that at the end of the course, you will be able easily to remember all the details in this classification. So we need to know what information do we tend to collect from these patients. If there are any abnormal symptom, and this can be very difficult to explain and to adopt from the parents and from the patients, what type of investigations they did and what type of investigations they need to do, and what are the treatment options of these patients. And it's not always that simple to have a blue baby or baby who have squatting to lead you. So teaching the parents and extracting information from the parents about the poor weight gain of the patient, pale of loose skin coloration, puffy face, irritability, fast breathing, sweating, if he sleeps a lot and is not playful with his colleagues, the easy fatigability, these are clues for congenital heart disease. We must also know the signs that we are collecting from these patients, like cyanosis, clubbing of fingers, respiratory distress, poor peripheral perfusion, decreased pulsation, difference in pulse, single second heart sound, abnormally loud second heart sound, prominent heart murmurs, and hyperactive pericardium. We must know the clinical indicators of increased pulmonary blood flow, which is increased respiratory rate, retractions and repeated chest infection, sweating while feeding, shortness of breath, failure to thrive, the presence of Harrison cycles, and increased lung vasculature in X-rays. And the concept of increased blood flow is very, very important. And it means that the lung and the pulmonary artery is receiving blood from its normal pathway on the right side and another abnormal pathway from the left side. And it goes without saying that these patients with increased pulmonary blood flow do not have cyanosis. And we must know the indicators of cardiac abnormalities in critically ill newborn. It might save us a lot of life. Primary desaturation, shock, and respiratory distress, and secondary murmurs, cardiac enlargement, and peripheral pulse. We must enlighten that what goes around comes around. So we must know what chamber will enlarge first in order to properly treat this patient. And the chamber that enlarge first is the first chamber that blood escapes from at the first place. And we must know and prevent to reach the end stage of Eisenmenger syndrome, in which there is permanent increase in the pulmonary blood pressure, leading to reversal of shunts from the right side to the left side, leading to very, very difficult and limited options of treatment. And thank you so much.
Thank you so much, Dr. Haytham, for an elegant, simplified presentation on how to approach congenital heart disease in both pediatrics and adults. And thanks for illustrating the point of parents' education, which I stress on. Patient education is very important in congenital heart disease. I have a couple of questions for you, and we have a question from the group chat. My couple of questions are, how does the degree of pulmonary blood flow affect the clinical presentation? The second question, in the current era of advanced investigations like multi-slice CT and cardiac MR, do you think we need ECG and chest X-ray to be implemented in our everyday practice?
Thank you so much, Dr. Khaled, for these important questions. Now, it's logic that if the pulmonary blood is increased, so this pulmonary blood or the pulmonary artery is receiving blood from two sources and not from one source. So it receives the common blood or the common blood from the right side, and it receives a blood from the left side. When you increase the blood to the lung, you will have more oxygenated blood, so you don't have cyanosis. So the reflection of increased pulmonary blood flow, first, it will decrease the cyanosis of the patient, or there will not be cyanosis for this patient, and it will increase the loads on the pulmonary circulation from the other side. So we are expecting more chest infections, more respiratory distress, and more affection of the right side and the pulmonary circulation than the left side at the first presentation. For the second question about the role of X-ray and ECG, of course, the X-ray and ECG are rapid, reproducible, and available sources for us to initially screen our patients and to rapidly determine whether this lung is receiving more blood, the pulmonary blood flow is increasing, so this lung has plethora, or there is decrease in the pulmonary blood flow, so this is an oligemic lung. Also, there is some features that are diagnostic from the X-ray to diagnose tetralogy of Fallot to diagnose TGA simply from the X-ray. The ECG is a very, very important tool, an essential tool to determine whether this patient has arrhythmia, whether this patient has chamber enlargement, whether this patient has any other anomalies than or channelopathy than the initial accompanying the initial congenital defect. So X-ray and ECG will remain and will prevail as initial tools for investigation these patients.
Okay, and we have one more question from the group chat. How would you identify heart failure in infants?
So this is, as I mentioned, is extremely difficult in infants. We must follow the symptoms and signs that we have. If this patient or this infant has difficulty in breathing, had difficulty in lactation, had difficulty in thrive, so we expect that this patient have a congenital heart disease or a heart problem. The second thing is to search about the signs. If this patient have an enlarged chamber, an abnormal heart sound, so we will relate these symptoms to these signs that the heart is the source of his problem. And of course, the gold standard answer will be by the echocardiography to illustrate whether this heart is failing or not.
Okay, thank you very much. As I said, it's not very easy to understand if there is a heart dysfunction in infants. So for instance, nowadays I have a patient in my ward of 3 months with a tachycardiomyopathy. And actually, while he was tachycardic, he was smiling and laughing to his mother. So the only sign that he had was actually he had some problems in feeding. So it's very tricky and difficult to understand when there is a cardiomyopathy in infants and newborns. So thank you very much for your explanation. Actually, I have 2 more questions for you. One, it's about investigation in patients with congenital heart diseases. As you know, today we have a lot of advanced techniques, in particular CT and MRI, that can give us a lot of information with no radiation or very low dose of radiation. So do you think that cardiac catheterism has still a role in the study of congenital heart diseases?
Yes. This is the other part of investigation, but it has the same answer of the initial primitive investigation. Every investigation answers a particular question that till now it could not be answered by the other investigations. For example, if we are seeking to know the exact pulmonary vascular resistance, if there is a discrepancy between the echocardiography and the answers by the MRI or the CT scan, these questions could not be answered unless we do a right heart catheterization or an invasive study for this patient. So the 2 main indications for cardiac catheterization nowadays is if there is a discrepancy between the other investigations, and the second is if we are calculating the pulmonary vascular resistance and saturations then accurately for these patients. Of course, CT and MRI, every one of them is answering a different question. If we're seeking the extracardiac information, the extracardiac structure, the CT is superior. And if we are seeking hemodynamics or shunt fractions, the MRI will be better than the CT or superior than the CT. But still, every investigation has a unique answer to a unique question. There is no investigation that can answer all our questions till now in the congenital heart disease field.
Okay, thank you. You've been very clear. Actually, I agree with you. It depends on the questions that you have on the congenital heart disease. So thank you. We have still one question from the audience. Let me check. How will time of one set of cyanosis would affect identification of etiology of congenital heart disease? So, yeah, I think that it's asking if the time when you see the cyanosis affect the etiology of the congenital heart disease, how this can impact on the diagnosis of the
diagnosis?
Yeah.
Okay, either this patient is cyanotic from the start, or this patient have an end stage condition of reversal of shunt, so the deoxygenated blood have the privilege and it's turning to the left side of the heart. So it's extremely crucial to identify and evaluate the pulmonary artery pressure in these patients, and whether these patients have initial cyanotic heart disease that can be treated easily, or these patients have reached the end stage of Eisenmenger physiology and the options of treatment is limited. Yes, the time of presentation is crucial in determining the fate of these patients.
Okay, thank you very much. You've been very complete. Khalid, do you have other questions?
One more question, Haytham. You mentioned in one of your slides the importance of diagnosing congenital heart disease early. As we diagnose congenital heart disease early, as we can treat early and prevent the stage of Eisenmenger. How can we predict the presence of the congenital heart disease from the early beginning?
Okay, it's all begin with the history. A very good history, and the history of consanguinity, which is extremely important. This will raise the doubts of that the condition of this patient is a congenital heart disease. If there is a history of congenital anomalies in the siblings of this family, or a positive family history of congenital heart disease, this will raise the doubts. If the mother have infections during pregnancy, had radiation during pregnancy, this will reflect that this patient might have a congenital heart disease. Actually, every detail, as Sarah mentioned, the only clue for her patient is that he has a feeding difficulties. So any problem or any item in the symptoms of this patient must be taken into consideration, not being taken lightly, because it can be the only clue that this patient has a cardiac problem and a congenital heart disease.
Thank you so much, Dr. Haytham, for your elegant illustration.
Thank you so much.
Thank you. I think that we can move on with a second presentation.
Okay, I'll stop sharing.
Yeah. So it's my pleasure to introduce Hatem Hosni. He is a consultant cardiac surgeon at the Haswan Heart Center. He's really expert on congenital heart disease courses. You can find very beautiful webinars on YouTube. So it's a pleasure to introduce him. He's gonna talk about pathology of left to right shunts.
Introduction, and I'm glad to be one of the team to present in this course. So this this talk is rather an introduction to the rest of the disease. It's not a specific disease as such. We'll be talking about pathophysiology of left to right shunts, and we'll probably be talking about general concepts so that we can move on with the course a bit easier. So as an overview, we'll be talking about systemic and pulmonary circulations, the concepts of flow, pressure, resistance, compliance. We'll have a talk about left to right shunts, essentially quickly going through ASD, VSD, and PDA pathophysiology with a special interest about gets enlarged. Then we'll be talking about restrictive and unrestrictive shunts and how does that affect the clinical presentation. Eisenmenger syndrome, and then what constitutes a clinically significant shunt. I will start with a simple few basic questions, just thought-provoking, and please let us what you think on the chat of Zoom or on YouTube, and then we'll collect the votes and go on. We all know that systemic pressure is higher than pulmonary pressure. So the pressure in the aorta is higher than the pressure in the pulmonary. Why do you think is that? So is that because the systemic flow is higher than pulmonary flow? Or is that because the LV is a stronger ventricle than the ventricle and so it generates higher pressure? Or is it because the systemic vascular resistance is higher than the pulmonary vascular resistance? So please let us know what you think. So question 2 is, if a patient has an ASD, and then this ASD shunts left to right, why do you think this happens? So is it because aortic pressure is higher than the pulmonary pressure? Is it because aortic flow is higher than pulmonary flow? Is it because LV compliance is less than RV compliance? Or because left atrial size is bigger than right atrial size? Or actually, ASD shunts actually right to left, not left to right. So choose an answer and let us know. Third question is, a patient with a large VSD, and then which ventricle do you think would dilate because of that VSD? Is it the right ventricle, left ventricle, both, or none? So these are the types of questions that we're going through in this talk. It's not a difficult talk.
Can you put every question for 10 seconds?
And the most important thing here is that not only you answer what are the correct answers.
Can you please put every question for 10 seconds, please?
Can we please? Yes, please.
So this is first question.
Yes, can we put every question for 10 seconds? Yes, leave it for 10 seconds, and then question 2 for 10 seconds, and then question 3 for 10 seconds.
A bit tricky questions that need concentration from all of us.
Why is systemic pressure higher than the pulmonary pressure? Because of flow or stronger ventricle or the resistance? Question 2, why does an ASD shunt left to right? Is it because aortic pressure, aortic flow, LV compliance, left atrial size? Actually, the ASD shunts right to left, not left to right. And then third question, a patient with a large VSD, which ventricle would dilate then? Is it right ventricle, left ventricle, both, or none? Please go through them and let us know what you think. So just answer 3 A or B, so then 2 and so and so. And then we'll go through the presentation, and then we try together to reach the answers for these, but importantly, why is that answer correct? So let's move on. So in a normal heart, the normal heart supports 2 circulations, the systemic circulation and the pulmonary circulation. So systemic venous blood, deoxygenated blood, comes back to the right side and then gets pumped into the pulmonary circulation. Then get back oxygen to the left side of the heart, which pumps the blood into the aorta and then goes back to the systemic veins, pulmonary circulation, pulmonary veins, systemic circulation, and keeps going so. This is very basic.
Hatem, I ask you to.
So we'll go through a very
Hatem,
basic
I think your connection is a little bit.
So that blood would flow. Very good. Yes.
I think your connection. Is
let me change connections.
Can you please change it? While you change it, just switch between the 3 questions on the screen for everyone, please.
Okay, let me change connection and come back.
Okay, no problem. Khalid and Zara can discuss.
Is it better now? Is it better now?
It's better. It's better. It's better.
Yeah.
Just go on.
Okay, go on. Can you start with the basic principles, the previous slide, please?
Yeah. So, this is the very basic fact about that. The heart supports 2 circulations, the systemic circulation and the pulmonary circulation. So systemic venous return gets back deoxygenated blood into the right side of the heart, which in turn pumps the blood into the pulmonary circulation, getting back oxygenated blood into the left side of the heart, which pumps blood into the aorta to the systemic. And then oxygen extraction occurs in the body, and then deoxygenated blood comes back to the right side, and then systemic veins, the right side of the heart, pulmonary circulation, pulmonary veins, left side of the heart, systemic circulation, and keeps going on. So very basic principles here. So blood flows from high pressure to low pressure chambers. This is quite basic. The second fact says that the chamber that gets volume load gets dilated. On the other hand, the chamber that gets pressure load gets hypertrophied. And now the important fact that in normal heart, systemic and pulmonary circulations flow in series. So they follow each other. So all the blood going to the systemic circulation has to come back from the pulmonary circulation. And all the flow going to the pulmonary circulation has to come back from the systemic. This is an important concept here. So blood coming back from the systemic circulation goes back to the heart and then gets to the lungs and then goes back to the heart and then comes to the systemic, back to the heart, to the lung, heart, systemic, and keeps going on and on in a very long queue. And so you can actually interrupt this whole queue and then both circulations will stop. For example, a patient who gets a massive pulmonary embolism, this event will stop both circulations because it's a very long queue and all the blood is going following each other. So we talk about flow. And we're more concerned here rather than the absolute amount of cardiac output. We're more concerned about the ratio between the pulmonary flow to the systemic flow. So Q here signs for flow. So QP is pulmonary flow, QS is systemic flow, and this is an important concept of the ratio between pulmonary flow to the systemic flow, QP, QS. So Khalid, we just said that systemic pressure is higher than pulmonary pressure. Do you agree?
Systemic pressure is for sure higher than the pulmonary pressure.
Sorry, I can't hear you. So you said systemic pressure is higher than pulmonary pressure. Do you agree on that?
I totally agree. For sure, systemic pressure is higher than the pulmonary one.
That's great. So do you think that the systemic flow is also higher than pulmonary flow?
I'll be answering the first question.
So important fact here is that although systemic pressure is higher than pulmonary pressure, but the flows are equal. Is a ton of iron heavier than a ton of cotton?
They are both equal.
They're both equal. And the important fact here, why is that equal? Because both circulations run in series. This is very important. So let's assume that this is a big room, and a few number of people are going from that door. So this is a big room. This is a narrow corridor, and this is a wall. So there's a door here, and another door there. And now people keep going from this room to that door, and gets crowded in the narrow corridor to go into the other room. So Khaled will be standing here at that room, at that door, counting the number of people in 1 minute. So number per unit time. This is very similar to flow of blood. So flow is volume per unit time. So if Khaled is standing here, counting the number of people, and Sarah is standing on the other door, counting also the number of people. So people can very easily go through that room and then cross that door, but the time crossing that narrow corridor to go into the other room. And then I'll ask Khaled and Sarah to tell me how many people did they count during the same time period. Although people have can very easily cross the room because it is very wide, since they have to cross the corridor to reach the room, and then they have to cross the room to reach the corridor, number of people per unit time at both doors will be equal. This is the same concept like systemic and pulmonary circulation. So if the systemic circulation has high resistance, while the pulmonary circulation has very low resistance, but still circulations are in series, the flow of both will be equal. So if someone is standing at the pulmonary valve, counting the volume of blood per unit time, and the other one is standing at the aortic valve, again counting the volume of blood at the same period of time, they should both count equal because the circulations run in series. But this can be very different if we open an opening inside the wall. And then people don't have to cross the corridor to reach the room. They can actually bypass. Then Sarah will count a lot more people than Khaled because now the circulations are no longer in series. People can take a shortcut to cross from this part to that part. And then the flow at this door will be much higher than that door. This is exactly the same that happens when there is an ASD, a VSD, or a PDA connecting both circulations. So we've agreed that the pulmonary flow is equal to the systemic flow. Then the flow of any circulations is equal to the pressure gradient across that circulation divided by the resistance, the vascular resistance in that circulation. And so since we have agreed that the systemic flow is equal to the pulmonary flow in a normal person, that means the ratio between the pulmonary, the pressure and the resistance of the systemic circulation is the same as the ratio between the pressure and the resistance of the pulmonary circulation. And in normal persons, the systemic vascular resistance is so much higher. So that the flow will be equal. One other way of saying this is that the left ventricle is facing very high resistance of the systemic vascular resistance. That left ventricle will have to exert a lot of pressure to be able to push that same amount against the high resistance. On the other hand, the right ventricle gets the same amount of blood, but once it starts contracting, it is faced by the very low pulmonary vascular resistance, and so the blood will easily cross the pulmonary circulation without the right ventricle having to generate high pressure. And so we've agreed here that the pressure is a byproduct. It is not an inherent thing of the circulation. It is a byproduct of the amount of flow having to cross the vascular resistance, which is characteristic for each circulation. So this should answer question 1. Have we got answers?
We have got a lot of answers from the group chat and from the YouTube, but I need to summarize before getting the answers. So the main concept is that we have a systemic and pulmonary blood flow and pulmonary circulation that are in series. And because we have a systemic vascular resistance that is much higher than the pulmonary vascular resistance, so the LV needs to generate a greater pressure than the RV. Am I right?
Yes, that's exactly right.
Okay.
I can just add a small note for our friends on the Zoom and on the YouTube, because there was a little bit of internet connection because of the sandstorm going on in Aswan. So usually the connection is a little bit twitchy. Sarah and Khalid, after Hatem finishes, they will rephrase and highlight the important points in the lecture and record it. And they will say it for everyone on the Zoom and on the YouTube live. And by the way, after the YouTube live is finished, the whole lecture is buffered and recorded in high definition by the YouTube channel. So you can just access it just 30 or 40 minutes later, and you will find it recorded in full high definition without any interruption. So no worries about the internet connection or the stuff like this. It's just something that's totally out of our hands, and it's totally fixed and manageable. You can proceed with the second question, Hatem and Khalid.
Okay, just we need to answer the first question. Why is the systemic pressure more than the pulmonary pressure? So Dr. Hatem, we can solve it simply by excluding that A is wrong, because both systemic and pulmonary flow are equal, as you just mentioned, that both circulation are in series.
Yes.
Second choice, B, LV is not stronger than RV, but it is obligated to generate a greater pressure to overcome the systemic resistance, which is higher. And
yes.
So the answer will be C. The systemic resistance is the key point of the equation. The systemic resistance is larger than the pulmonary resistance, and that's why the LV needs to generate a greater pressure more than the RV to end in the result that both circulations are flowing smoothly in series.
Exactly. And just to stress that fact, the LV has become stronger because it has to generate higher pressure, and so it adapts with more wall volume. On the other hand, if a patient has a transposition of great arteries, the systemic circulation will be supported by the right ventricle, and still the systemic pressure will be higher than the pulmonary pressure. So it is an inherent fact of the resistance. Thank you, Khalid. So moving on, we've just agreed that pulmonary vascular resistance is so much lower than the systemic vascular resistance. But this is something that occurs after birth. So during the fetal life, pulmonary vascular resistance is actually quite high. And these are because of different reasons. So the lungs are collapsed, there is no air there. So the lungs are compressing the blood vessels. So the pressure, the resistance is higher. And on the other hand, inhaled oxygen is a potent pulmonary vasodilator. And obviously during the fetal life, there is no inhaled oxygen. And so the pulmonary vascular resistance during the fetal life is actually quite high. At birth, pulmonary vascular resistance acutely drops, but then it still does not reach the adult level. And it continues to drop further for like 6 to 8 weeks after birth. And this actually has implications during left to right shunts. So moving on to shunts. So if a patient has a communication between the aorta and the pulmonary.
Dr. Hatem, sorry for interruption, but can you please repeat the previous slide, because I think this is an important point in the transmission between the fetal and the fetal circulation and the postnatal circulation. This is a very important point, and it affects markedly the clinical picture, the clinical presentation of patients with left to right shunts being completely asymptomatic while pulmonary vascular resistance is high, and then they start dramatically to be symptomatic once the pulmonary vascular resistance drops.
Exactly. So a major part in the pathophysiology of blood flowing from left to right side is that the pulmonary vascular resistance in normal is so much lower than the systemic vascular resistance. And so the pulmonary pressure normally is so much lower than the systemic pressure. And so if a connection occurs between both sides, then blood will flow from the high pressure to low pressure. And the pressure was high in the first place because of the difference in the resistance. But on the other hand, just make sure you know that during the fetal life, pulmonary vascular resistance normally is quite high. So immediately after birth, pulmonary vascular resistance sharply drops, but then it still remains higher than normal and stays for that like 6 to 8 weeks. It takes like 6 to 8 weeks for the pulmonary vascular resistance to drop to its adult level. And so if there is a communication between both circulations, you would not expect the shunting to be very high during the first few weeks. And so most patients with these shunts do not have marked symptoms during the first few weeks. And then you start getting more symptomatic and the pathophysiology gets more obvious as the baby grows older, crossing 2 months of age. So again, talking about shunts. So now we've agreed that the aorta is a part of the systemic circulation, or the pulmonary artery is a part of the pulmonary circulation. Sometimes you can get a communication between both. So a connection between aorta and pulmonary, most obviously, is patent ductus arteriosus. So how would you expect blood to flow? Is it aorta to pulmonary or the other way around? So we've just agreed that blood flows from high pressure to low pressure. And since the pressure in the aorta is higher than the pulmonary, so flow will be going from aorta to pulmonary. Why is the pressure higher in aorta than the pulmonary? Because the systemic vascular resistance is higher than pulmonary vascular resistance. So the blood having to cross the systemic circulation has to be at higher pressure than the pulmonary pressure. So a connection between aorta and pulmonary, namely a PDA, the PDA will flow left to right, I mean aorta to pulmonary. So if a patient gets a VSD, so communication between left ventricle and right ventricle, how would the blood flow? So again, the pressure in the left ventricle is higher than pressure in the right ventricle because the pressure in the left ventricle is equal to the pressure in the aorta, which is higher than the pressure in the pulmonary. And then the pressure in the aorta is higher because the systemic vascular resistance is higher. So the left ventricle has to generate higher pressure than the right ventricle. And so normally LV pressure is higher than RV pressure. So the flow across the VSD is also left to right. One important thing to note here is that, do you think the flow in the PDA was systolic, diastolic, or both? So let's take a normal adult, and then an example for that would be that aortic pressure in a normal adult would be something like 120 over 80. So systolic 120, diastolic of 80. While on the pulmonary artery pressure in a normal person, it would be something like 25 over 10. So during systole, there is a difference in pressure. So blood will flow from aorta to pulmonary during systole, but also during diastole. The pressure in the aorta is 80, while the pulmonary is 10. So again, also the blood will flow from aorta to pulmonary. So during systole and diastole, blood will flow across the PDA. On the other hand, the pressures in the left ventricle and right ventricle are very different during systole, because during systole, both valves are open, aorta and pulmonary valves. So the LV pressure would be similar to the aortic pressure, something like 120, while RV pressure is similar to the pulmonary pressure, also something like 25. So blood will flow during systole from LV to RV. On the other hand, during diastole, aortic valve and pulmonary valve both are shut. And so the left and right ventricle are not communicating with their arteries. So the difference in LV and RV diastolic pressure are quite very similar to each other. So LV pressure is slightly higher than RV pressure, diastolic. And so the flow in the VSD is predominantly systolic flow. And this is actually has clinical implications. So the murmur of the flow of the PDA is continuous murmur, while the murmur of the VSD is actually a systolic murmur. So let's take an example of a communication between left atrium and right atrium. We're talking about an AZ, atrial septal defect, a communication between the left atrium and right atrium. So how do you think blood will flow? Is it left atrium to right atrium or the other way around?
For sure, it will be from left atrium to right atrium. I think we will have
Great.
now an answer for question number 2.
Yes, that was the second question.
Again, for the audience, the question number 2 was, why does an ASD shunt left to right? Choice number A, aortic pressure more than pulmonary pressure. Choice B, aortic flow more than the pulmonary flow. Choice C, LV compliance is less than the RV compliance. Choice D, LA size is more than the right atrium size. Choice E, ASD shunts right to left. I think we need an illustration from you, Dr. Haid.
So shall I go on?
Yes, please.
So
It's a bit tricky question.
it is. So let's think of that. Okay, systemic pressure is higher than pulmonary pressure, and that's why blood should go from left to right. Yes, that's true. But the systemic pressure is the pressure in the aorta and the pulmonary. And we have agreed that pressure in the aorta is higher than the pulmonary because of the resistance. But then the atria do not communicate with the arteries. So although the pressure in the left, in the aorta is higher than pressure in the pulmonary, but then the atria only communicate with the ventricles. Atria communicate with the ventricles during diastole. And during diastole, aortic and pulmonary valves are shut. So the high pressures in the systemic and the pulmonary circulation are not transmitted to the atria. On the other hand, during systole, when the ventricles communicate with the arteries, the mitral and tricuspid valves are shut. So again, this high pressure is not transmitted to the atria. So the answer is yes. Flow goes from left atrium to right atrium, because left atrial pressure is higher than right atrial pressure. But why is that? Actually, because the pressure in the aorta is higher than the pulmonary. But actually indirectly. So since the pressure in the aorta is higher than pressure in the pulmonary, the left ventricle will have to exert more pressure for the blood to go against this high resistance. And we've said that the chamber that gets pressure load has more wall thickness. So we do not call that as hypertrophy because this is physiological. But for sure, the LV wall thickness is much more than RV wall thickness. The RV wall thickness is very thin. And so blood goes to the left ventricle more difficult than blood going from right atrium to the right ventricle. And this is the concept of compliance. So compliance is the volume that the chamber can adapt without changing pressure. So if we have like 20 mils of blood, 50 mils of blood, having to go from left ventricle, left atrium to left ventricle. And same amount of blood having to go from right atrium to right ventricle. So pressure in the right ventricle will rise a lot less in the right ventricle than left ventricle because LV wall is much thinner, RV wall is much thinner than LV wall. You can think of that like someone trying to blow into the balloon. So if this balloon has very thick wall, he will get hard time blowing into the balloon. And so we say that the compliance of the balloon is low. So this is like the left ventricle. While on the other hand, if the balloon is very thin walled, the person can blow easily into the balloon. And so more volume will go in without increasing in pressure. And so to summarize, LV and the diastolic pressure is slightly higher than RV and diastolic pressure. And that's why left atrial pressure is slightly higher than right atrial pressure. And so the net flow across the atria is left atrium to right atrium, left to right shunt.
That's a very nice illustration, Dr. Hatem. Maybe we would like to interrupt you here just for a few seconds before you move on. We have a special request from Dr. Iman Ali. She was asking you please to rapidly repeat the VSD, the previous question, in a just simple way so we can match the VSD and the ASD together. And also this is a special request from my own.
So shall I repeat why the blood flows VSD left to right and ASD left to right? Is that the question?
Yes, please. In one sentence or in one paragraph, so everyone can match them together in his own brain in a proper way that it will never be forgotten again. Because I love this way you illustrated so much.
Thank you. So systemic vascular resistance is higher than pulmonary vascular resistance. LV will have to generate high pressure to push the same amount of flow from the left ventricle to the aorta than right ventricle to the pulmonary. And since the LV systolic pressure is higher than RV systolic pressure, if there is a communication in between, blood will go from high pressure LV to low pressure RV. So flow across VSD is left to right, and it's almost only systolic. In the ASD, things are indirect. So because the LV pressure is higher than RV pressure, the LV wall thickness gets, with time, gets thicker than RV wall thickness. And so the left ventricle will have more difficulty adapting more volume. So to adapt more volume into the left ventricle, pressure will go higher. This is a diastolic event when the blood flows into the left ventricle. So left ventricular end diastolic pressure is higher than right ventricular end diastolic pressure, because compliance of the left ventricle is worse than compliance of the right ventricle, because the LV is subjected to higher pressure than the RV. And so the net flow across an ASD is left to right because of the worse compliance of left ventricle than right ventricle. So the question, why does an ASD shunt left to right? It is because the difference in compliance between left ventricle and right ventricle, and not because of the other reasons. Obviously not because ASD shunts right to left.
Okay, Dr. Hatem. So to sum up, although they are all left to right shunts, but the shunt timing is different due to the difference in pressure. In PDA, the shunting is both systolic and diastolic because we have always a pressure difference between the aorta and pulmonary in systole and diastole. The shunting in the LV, in the VSD, is systolic because there is a difference in the pressure between the LV and RV during systole, while we don't have a pressure difference between both ventricles during diastole.
During diastole, it's minimal.
Okay, it's minimal. In ASD, it is an idea of the LV and RV compliance. The LV compliance is less than the RV compliance. Or we can say it in another way, the LV end diastolic pressure is slightly higher than the RV end diastolic pressure. And that's why the ASD shunts during systole from left to right.
Yes, think of the balloon.
Okay. Thank you so much for this elegant illustration.
Thank you. Thank you. So let's go on. So now we talk about ASD, VSD, and PDA, and how the blood actually flows. So this is a block diagram from the very nice book Park, which I highly recommend. So this is an illustration of a heart that has an ASD. So these are systemic veins, SVC, IVC, going to right atrium, right ventricle, pulmonary artery, and then blood goes to the lung and come back into pulmonary veins going to left atrium, left ventricle, aorta. And then now this heart gets a communication between both atria. We've just agreed that LA pressure is slightly higher than right RA pressure. And so blood will go from left to right, left atrium to right atrium. But we've also agreed that the chamber that gets volume load gets dilated. So let's think together. If a patient has an ASD, what chambers will get dilated? We can easily think of that by pointing out which chambers get more blood. So the chamber that gets more blood, gets volume load, will get dilated. So do you think, Khaled, SVC, IVC will get more blood?
For sure, no.
No? Right atrium?
Right atrium will get more blood.
Yes, it will get more blood. Right ventricle?
Yes.
So whatever goes to the right atrium will go to the right ventricle. So right ventricle will get more blood. Pulmonary arteries?
Also will get more blood.
Or more blood. Pulmonary veins?
Will get more blood.
Will get more blood. Left atrium? Yes, will get more blood. So if I'm standing here, I will count more mils of blood going into the left atrium. Left ventricle?
Will not get more blood.
Yes, because the blood that should have gone into the left ventricle have passed through the ASD.
Right side.
So yes, so this will get less than normal blood. And aorta?
Will get less blood as LV.
Will less blood as well. Great. So we've agreed that right atrium, right ventricle, pulmonary arteries, pulmonary veins, and left atrium will actually get more blood. Do you think all of them will get dilated?
No.
So all of them except left atrium. Although left atrium gets more blood, it does not get dilated in a patient with an ASD. Why is that? Okay, I've said that chambers that get volume load will get dilated. I've just not said that the blood has to stay long enough in that chamber so that it stretches the wall of the chamber, and then the chamber will get dilated. The blood coming back from pulmonary veins into left atria just cross the ASD immediately. It does not stay long enough in the left atrium to stretch its walls, and so that the left atrium will not get dilated in a patient with an ASD. So it will just cross the left atrium into the ASD going to the right atrium, while the rest of blood will go to the left ventricle. So although technically more blood passes through left atrium, it passes quite quick so that it does not stretch its wall. So left atrium does not get dilated in a patient with an ASD. So you can see here that right atrium, right ventricle, pulmonary artery, pulmonary veins get dilated in an ASD, while left atrium, left ventricle, aorta, and systemic veins do not. So roughly, the right side of the heart, in addition to the pulmonary vessels, get dilated in an ASD. So ASD, dilated right side of the heart. This is important because you can notice that in simple investigations. So you can notice that in that plain film, in the chest X-ray. So you can notice signs of enlarged right atrium and right ventricle. You can also notice the enlarged pulmonary artery shadow and more blood flow pulmonary vessels inside the lungs. So let's clear that term. So more blood goes into the lungs and come back from the lungs. So pulmonary vessels, arteries, and veins will be dilated because of more flow. This is technically called plethora, lung plethora. On the other hand, the term congestion is more like pulmonary venous obstruction, which does not happen here in left to right shunts. We have some problem here that it is very prevalent across people working in congenital to say that the lungs are congested when they actually mean plethora. So if you hear the term congested lungs, it's not like pulmonary venous obstruction. They just meant plethora, I mean more blood flow. This is not a very correct term, but it is very prevalent there, so that people say lungs are congested.
Dr. Hatem, we have a question from the audience. They are asking, Dr. Hatem Salimani asking, what is the effect of hypertension on ASD?
Pulmonary hypertension.
No, I mean, is meaning the systemic hypertension.
Systemic hypertension.
Yeah, I think so, yes.
So if a patient gets systemic hypertension and at the same time he has an ASD, technically more blood will flow from across the ASD, because if a patient has systemic hypertension, the LV wall thickness will get even more thicker, and then the LV compliance will be even worse, and so shunting across the ASD will be even worse. If the question was pulmonary hypertension, characteristically pulmonary hypertension occurs in ASD very, very late, because pulmonary vascular resistance is very low. So it can adapt a lot of increase of pulmonary flow without increasing pressure. We've just said that flow is equal to pressure divided by resistance. On the other hand, we mean that the pressure is equal to the flow multiplied by the resistance. The resistance is really, really low. So whatever you increase, however you increase the flow, will not get high pulmonary pressure except very late. So patients who are 2, 3, 4 years of age with a big ASD and big shunt should not get pulmonary hypertension. Pulmonary hypertension occurs with ASDs very, very late, like 30, 40, 60 years.
Yes.
Have I answered your questions?
Thank you.
Thank you. So we were talking about how can we detect chamber enlargement? By simple investigations. So a question was asked during the previous talk about the value of ECG and a plain chest X-ray in the era of CTs, MRI, and echo. So in a very simple investigation that you can do bedside or in the clinic, you can detect important information like pulmonary plethora, chamber enlargement of different chambers, either right side or left side. You can detect that by ECG and by plain chest film. So yes, we do depend heavily on these simple investigations because they build big parts of the big picture.
Okay. Dr. Hatem, before moving to VSD, I have a question. As you mentioned, the blood flow does not stay so much in the left atrium and shunts directly to the right atrium, and that's why the left atrium doesn't dilate.
Yep.
When do we expect seeing a small left atrium?
So if there is massive shunt from left to right, I do not want to complicate things here, but the ASD physiology is really, really marked in patients with total anomalous pulmonary venous connection. And then it has the physiology of an ASD because the whole pulmonary flow comes back into the right atrium, and then really small amount of blood goes to the left atrium, and then you get really small left atrium. But otherwise, with ASDs, patient with the left atrium is not dilated, still adequate size.
Okay. And another question from the group chat regarding the issue of systemic hypertension, and you just mentioned that the LV end-systolic pressure will be much higher, and so the left atrial pressure will also be very high. Do you think is it wise in elderly patients with elevated left atrial pressure? Is it wise to close the ASD while we have a high left atrial pressure?
So in this subgroup where patients have big ASD and they have been like that for a really long time, remember that the more the volume, the more the size of the chamber. So LV has never seen a lot of volume. And so the compliance in these patients are actually quite low. If they also get systemic hypertension, and so the wall thickness is really, really thick, closing the ASD immediately will cause significant increase in LA pressure. And this can actually be reflected into back into the lungs. And so one should be quite careful to close big shunts in elderly patients with high LA pressure. Actually, also after closing ASDs, one should be careful of not giving a lot of volume into the both circulations, because left atrial pressure can get actually quite high, and LV pressure can get LV end-systolic pressure can get quite high.
Okay.
Does that answer you?
Yes.
So shall we move on?
Yeah, please.
Now we talk about VSD, so communication between both ventricles. So again, we'll go through the same way. Systemic veins do not get high flow. Right atrium does not get high flow. Right ventricle actually gets higher flow by the flow across the VSD from left ventricle to right ventricle. So pulmonary artery gets more flow. Blood comes back to the pulmonary veins, higher flow. left atrium, higher flow, left ventricle, higher flow, more blood. Aorta does not get, because the blood that should have been going to the aorta goes across the VSD. So we've agreed that pulmonary artery, pulmonary veins get more flow, so they get dilated, more volume. Left atrium gets more volume. And then what about the ventricles? Left ventricle and right ventricle. So also I've agreed that for a chamber to dilate, more volume has to stay long enough in that chamber so that it stretches its wall till it gets dilated. Blood flows from the left atrium to the left ventricle during diastole. And so the left ventricle will get more volume during diastole, and the walls will get this stretched. So left ventricle dilates in a patient with a VSD because the pulmonary flow is higher, pulmonary venous return is higher, and so diastolic flow into the left ventricle is higher. But remember, we have agreed that flow across the VSD is predominantly systolic. So right ventricle gets more volume of blood during systole. During systole, the right ventricle is contracted. So it does not adapt more volume. The volume will not stretch the walls of the right ventricle. This blood will just use the right ventricle as a pathway into the lungs. So although more volume technically goes into the right ventricle, normally right ventricle does not get dilated in a patient with a VSD.
I enjoy this part so much, actually. I enjoy this particular part so much, Hatem. You explained something to me that I have been not understanding for the past 16 years. So I get a special request actually from the YouTube, Dr. Hatem. For the first time, we imagine that the right ventricle is not dilated in the VSD, and for the first time we know why the right ventricle is not dilated in the VSD. May I ask you please, Hatem, to just wrap it up in less than 10 seconds again?
Yes. So VSD flow left to right, so more blood goes into the pulmonary circulation, more blood comes back to the pulmonary veins, more blood into left atrium, more blood into left ventricle during diastole. Flow across the VSD is systolic. So during the whole diastole, more volume will stay in the left ventricle, stretching its walls. So left ventricle gets dilated in the VSD. Since the flow across the VSD is a systolic event, so when more volume goes into the right ventricle at that time is contracted. Blood will not stay in the right ventricle long enough to stretch its walls. Actually, it will use the right ventricle as a pathway from the left ventricle into the pulmonary arteries. So right ventricle does not get dilated in patients with a VSD. On the other hand, left ventricle will get dilated. So to keep things simple, patients with VSD gets dilated pulmonary artery, pulmonary veins, and left side of the heart. So let's keep things simple. At any left to right shunt, either ASD, VSD, or PDA, flow into the lung vessels is more than normal. So pulmonary artery and pulmonary veins will get dilated at any of the left to right shunts. In ASD, the right side of the heart dilates. In VSD, the left side of the heart dilates. Is that clear?
Yes, it's clear, Dr. Hatem. And I think we have just answered question number 3. In a patient with a large VSD, which ventricle dilates? I think the answer is B, left ventricle, and not as RV. And we can say it again in another way, that we could consider as RV as just a tunnel shunting blood from the left ventricle directly to the pulmonary artery.
Exactly.
Thank you very much. Actually, this explanation is very useful for the beginners because when you don't think to the pathophysiology, you start to suppose that in both the defects there is an enlargement of the right ventricle, but it's not like this. And thank you for explaining why We have a question from the audience from Dr. Mohammed Safi. He said that as it is illustrated that the cause of shunting in ASD from left to right is due to the difference in ventricular compliance. So one would expect that the flow will be mainly in diastole, which is not true. What is the explanation? So actually he is asking why the shunt in the ASD is not doing the diastole.
Sorry, can you repeat that again?
Yes, the doctor is asking why the shunt in the ASD is not during the diastole time by during systole.
Because during diastole, most of blood will be going into the ventricles because mitral and tricuspid are open. So the ventricles are actively sucking blood into the ventricle because diastole is an active event. But the left ventricle gets higher pressure and diastolic pressure a lot quicker than the right ventricle. So the pressure in the right atrium, even during diastole, the left atrial pressure will be slightly higher than right atrial pressure, and then you get flow during the ASD because of the less compliance of left ventricle than right ventricle.
Okay, yes. Thank you very much for your answer.
Dr. I had another question from the audience. Why does a VSR with myocardial infarction complications dilate RV acutely, particularly those big VSRs? Why in patients with complicated myocardial infarction is VSR with the right side or RV more dilated than the left ventricle?
So, sorry, I did not get your question. Sorry again.
Why does VSR with myocardial infarction complications dilate RV acutely, particularly those big VSRs?
Okay, patients with ischemic VSD or ventricular septal rupture, in addition to the physiology of the VSD, they get an important physiology of ischemia. So there is a significant ischemia affecting the ventricles, which might very well involve the right ventricle. So right ventricle can be affected because of that. Another very important thing here is that normally in an adult, the right ventricular pressure has always been very low. And then it suddenly, acutely gets exposed to really high pressure, the systemic pressure. And then right ventricle fails because of the acute increase in the right ventricular pressure. So this is a bit of more added factors in addition to the just shunting of the VSD itself.
Okay, so the main idea is the acute insult.
Yes, yes, which is very, very different because patients with congenital VSDs, they very rarely get early right ventricular failure, while in ventricular septal rupture, you can get that very easily because of the acute event.
I think for sake of time, we need to move to the PDA physiology.
Yes. So shall I move on?
Yes, please.
Again, something very related to VSD, the concept of a restrictive versus unrestrictive VSD. This is an important concept. What is restrictive VSD? So a restrictive VSD is a VSD that is small enough that it restricts blood flow so that it does not allow equalization of pressures across the VSD. So let's say that again. So for a VSD to be restrictive, it has to restrict blood flow from the left ventricle into the right ventricle so that the left ventricular pressure will stay significantly higher than right ventricular pressure. Let's give an example of that. Let's assume that this is the room and the air conditioner of that room is broken. So it keeps pumping air inside the room and does not get air out. So the pressure inside that room is really, really high, okay? And now you get a small hole in the wall of that room. So the pressure inside the room is high, the pressure outside the room is low. And so since flow goes from high pressure to low pressure, if there is a small hole here, there will be a jet of air going out through that small hole. So if someone is standing outside here, he will notice the jet of air coming out of the room. But still, this hole is very small. It does not allow equalization of pressures. The pressure inside the room will still be higher than outside, okay? Let's assume that we have taken the whole wall out. And then this high pressure will just push the air all outside. And so you can easily get equalization of pressures. This is similar to a VSD. If the VSD was very small, LV pressure will still be higher than RV pressure. There might still be significant flow across the VSD. The pulmonary flow can still significantly be higher. The left side of the heart can still get volume load, but the RV pressure and the pulmonary pressure are significantly lower than systemic pressure. This is a restrictive VSD. Patients with unrestrictive VSD, the VSD is large enough so that it allowed equalization of pressures between left ventricle and right ventricle. And so during systole, the LV pressure, which is equal to the aortic pressure, will also be equal to the RV pressure, which will also be equal to the pulmonary pressure. So aortic pressure, LV pressure, RV pressure, and pulmonary pressure will nearly be equal. This is unrestrictive VSD. So restrictive VSD is a small VSD with low pulmonary pressure. Unrestrictive VSD is a large VSD with high pulmonary pressure. This makes a big difference in the pathophysiology, presentation, and the timing of management in these patients.
Okay, and for sure, the pathophysiology would affect the clinical picture and would affect the chamber enlargement. We have here a question from Dr. Karim Mahmoud. Why in non-restrictive VSD both ventricles will dilate?
Sorry?
We have a question from Dr. Karim Mahmoud. Why in non-restrictive VSD both ventricles will dilate?
So patients with unrestricted VSD will have high pressure in the right ventricle, high pressure in the pulmonary artery, a lot of blood flow into the lungs. The right ventricle still acts like the tunnel. The right ventricle should not dilate in unrestricted VSD, but on the other hand, a chamber that gets pressure load gets hypertrophied. And the right ventricle now is exposed to high pressure of the systemic and pulmonary pressure. And so the right ventricle gets hypertrophic and not dilated. This is obvious in this diagram. So this is a patient with a small, very restrictive VSD with hardly any flow across. And so there is some dilatation in the left side, but the RV pressure is low, and you can hardly see any signs in X-ray and ECG. The larger the VSD, the more signs and symptoms for the patients. So in moderate VSD, you get moderate signs of cardiomegaly on X-ray and ECG, and RV pressure is approaching half systemic. Large VSD gets significant dilatation, but also hypertrophy of the right ventricle. So you get dilated left side and RV hypertrophy. This is evident in chest X-ray, where you get the cardiomegaly showing signs of enlarged left ventricle and left atrium, in addition to the large pulmonary artery shadow and the pulmonary plethora showing increased vascular markings in the lungs. And obviously the ECG signs. So patients with VSD get left atrial enlargement and left ventricular enlargement. If the pulmonary pressure gets high, you can also get on ECG signs of RV hypertrophy. Now we move to PDA. So now this patient has a communication between the aorta and the pulmonary artery. So we go through cardiac chambers, SVC, IVC, no increased flow, right atrium, no increased flow, right ventricle, no increased flow. But then pulmonary artery will get increased flow. Pulmonary veins gets increased flow. This increased flow goes to the left atrium, left ventricle. And here you can also see the ascending aorta till the level of the PDA, which is at the end of the aortic arch. All of that part of the aorta gets higher flow. So this part of the aorta also gets dilated. So in patients with PDA, they get dilated pulmonary artery, pulmonary veins, left atrium, left ventricle, the part of the aorta proximal to the PDA. So to summarize, patients with, so any left to right shunts get dilated pulmonary artery and pulmonary veins. Patients with ASD get dilated right side of the heart. Patients with VSD and PDA get dilated left side of the heart. Also, you can see that on the chest X-ray and the ECG. And in the PDA, you can also notice that the ascending aorta till the arch are also dilated. So blood keeps going from left to right, be it an ASD, a VSD, or a PDA. Blood will continue going from left side of the heart into the right side of the heart. So the pulmonary circulation gets a lot more volume than normal. So more fluid will be filtered into the lung interstitium. And so the exchange of gases across the lung gets more difficult. So these patients get tachypnea. So they have difficulty of breathing because now exchange of gases across the lungs is more difficult. More fluid stays into the lung interstitium, which is a culture medium. So you get more chest infections. Very small babies with very large VSD or a large PDA get really big flow into the lungs. So they get very tachypnic. They have to stop feeding to take their breath. So they are exerting a lot of effort and they are not feeding well. So they do not grow well. So we get the signs of tachypnea, recurrent chest infections, and failure to thrive. This can get very serious. And some patients can actually get serious heart failure, pneumonia, and can get death because of the very high left right shunts. So the lung starts defending itself. So the pulmonary arterioles gets vasoconstricted so that the pulmonary vascular resistance will increase. And so the amount of blood going into the pulmonary capillaries and getting filtered into the interstitium gets less. And so actually the symptoms improve. So they improve by vasoconstricting pulmonary arterioles. This causes increase in pulmonary vascular resistance. And so the magnitude of the shunt will become less because now the pulmonary vascular resistance has increased. So the difference between the systemic vascular resistance and the pulmonary vascular resistance, the difference gets less. So the shunting across the VSD gets less. And so the symptoms actually improve. And then we take that patient, we take him to theater or cath, and then close the VSD. And then the pulmonary arterioles will vasodilate again, and pulmonary vascular resistance drops again. And this is the good scenario. So the increase in the pulmonary vascular resistance at that point was reversible. So at first, patients get very high pulmonary flow because of the left to right shunt. And they get signs and symptoms of high pulmonary flow, including tachypnea, chest infections, failure to thrive. Then reversible increase in pulmonary vascular resistance occurs by vasoconstriction in pulmonary arterioles. And so the symptoms start to improve, but this is because of increased pulmonary vascular resistance. And during that stage, it is still reversible. So once the shunt is closed, things come back. But on the other hand, if this defect was not closed in time, the pulmonary arterioles will stay vasoconstricted, stay vasoconstricted, stay vasoconstricted till fibrosis occurs. And now the increase in pulmonary vascular resistance is no longer reversible. They get irreversible increase in the pulmonary vascular resistance. The patient will report improving symptoms. So the family says, okay, he used to get lots of chest infection. He was not growing well. He was very sick. And then now the symptoms are improving and he's not that sick. But they also start noticing that the patient becomes blue, because with the high increase in the pulmonary vascular resistance, now the pulmonary pressure gets really high, to the extent that it gets higher than the systemic pressure. And now the shunt reverses because blood will flow from high pressure to low pressure. And now the pulmonary pressure can be higher than the systemic. So the blood will flow from right ventricle to the left ventricle, right to left. So the shunt reverses. The blood in the right ventricle comes from systemic veins. So this is deoxygenated blood. So with the very much increase in the pulmonary vascular resistance, blue blood will go from right ventricle to left ventricle. And then enough deoxygenated blood will go into the aorta so that cyanosis occurs. So why does a patient get central cyanosis? Because there is enough deoxygenated blood that goes into the aorta. This condition, where a patient used to have very big left to right shunt, and this very big left to right shunt caused increase in the pulmonary vascular resistance. And this increase has become irreversible, so that the shunt reverses and becomes a right to left shunt, so that enough deoxygenated blood goes into the aorta and patient gets cyanosis. This condition is called Eisenmenger syndrome. So this was a patient that had a big left to right shunt. You can appreciate the cardiomegaly, the enlarged pulmonary artery shadow, the pulmonary vascular markings. And this is after this patient has become an Eisenmenger syndrome. Now the pulmonary flow has become much less because blood across the VSD is now right to left. So less blood goes into the lungs because the pulmonary vascular resistance is very high. And so the left ventricle will not get high pulmonary venous return. The high pulmonary flow was translated into high pulmonary venous return, and so more blood into the left ventricle, and so the left ventricle was dilated, and you could have appreciated the cardiomegaly. Once the pulmonary blood flow has decreased, the pulmonary venous return also decreases, so the blood filling the left ventricle is much less, and so the cardiomegaly reverses. And so a patient with Eisenmenger syndrome has no cardiomegaly, has lungolegemia, but you can still appreciate that the pulmonary artery shadow is big because pulmonary artery pressure is high, and this pulmonary artery is distended. So Eisenmenger syndrome is a sad thing because this is a totally preventable disease. Patients should not become Eisenmenger if we treat them early enough. This can happen in any left to right shunt, but obviously it happens a lot earlier with patients that have very high pressure in the pulmonary circulation. So patients with big VSD and big PDA can get Eisenmenger syndrome quite early as 2 to 3 years of age. On the other hand, patients with ASD, although the pulmonary blood flow is much higher, the lungs are not directly exposed to the high pressure of the systemic circulation. And we have said that the very low pulmonary vascular resistance can adapt a lot of volume. What happens in the VSD and the PDA is that the pulmonary vessels are exposed to the very high systemic pressure. And so that's why the changes occur very early. But in ASD, patients can stay as long as 40 to 60 years before getting that. Now, if we close this big VSD, now the right ventricle will have to face the very high pulmonary vascular resistance on its own. It used to shunt this, a part of that blood across the VSD into the systemic. If we close that VSD, the right ventricle will have to push that whole amount of blood across the pulmonary vascular resistance, which is really, really high. If we do that, the right ventricle gets acute failure. Patient can die on table in theater if we close a VSD in a patient with established Eisenmenger syndrome. On the other hand, if a patient has Eisenmenger syndrome, he can stay as long as more than 20 years before mortality. So the median survival after established Eisenmenger syndrome is roughly 20 years. About half of the patient can stay alive for as long as 20 years. So the natural history of the Eisenmenger syndrome is so much better than if we close the shunt. So if a patient gets Eisenmenger syndrome, obviously he should not get the Eisenmenger syndrome in the first place if we treat him well. But on the other hand, if the patient gets very late treatment and does not get the shunt closed and he gets established Eisenmenger syndrome, he should not get the shunt closed because otherwise the mortality is much higher. So Eisenmenger syndrome is a preventable disease. Irreversible increase in pulmonary vascular resistance increased with unrestricted VSD after roughly 2 to 3 years of age. When that happened, the closure of the shunt is contraindicated. On the other hand, the median survival with unrepaired, unrestricted VSD is roughly 20 years. On the other hand, patients with ASD develop Eisenmenger syndrome very later, something like 40 to 60 years of age. How do we diagnose that a patient is an Eisenmenger syndrome? So clinical first, before going into cath and things like that, you first think about the age of the patient and the type of the disease. Patients at 3 months of age cannot be Eisenmenger. On the other hand, if a patient has an ASD and he is 2 years of age, he should not be an Eisenmenger syndrome. So you first think, what is the disease? Is it a VSD, unrestrictive, or a small ASD? What is the age of the patient? Is he at 2-3 months of age, or is he at 20 years of age? So age of the patient, type of the disease, history. So classically, they have got significant symptoms of left to right shunt, failure to thrive, recurrent chest infections, failure to tachypnea and things. And then symptoms of the heart failure improve. And then they start reporting cyanosis. Cyanosis is one thing, and pulse oximeter is another thing. So if a patient reports cyanosis, this is something, but then you can do pulse oximeter. Patients with Eisenmenger syndrome, usually get saturations of low 90 to 80s. So again, age of the patient, type of the disease, symptoms, pulse oximeter, chest X-ray, you get oligemia, no more cardiomegaly, and large cardiac shadow. The ECG shows no dilated left-sided chambers, and actually shows signs of right ventricular hypertrophy. You do echo, and you find the large VSD, and the shunt across the VSD is right to left or bidirectional. You estimate PA pressure by echo, and you find it very high. Then you do cath. By cath, you can find high right ventricular pressure, high pulmonary artery pressure, with increased pulmonary vascular resistance. Is that increase in the pulmonary vascular resistance, is it reversible or irreversible? We test that by giving a pulmonary vasodilator. So a very potent pulmonary vasodilator is nitric oxide. This might not be available in some countries. So the other alternative is putting the patient on 100% oxygen. And then you repeat cath measurements with 100% oxygen. So you do the cath, and you measure high PA pressure, high pulmonary vascular resistance. And this is at room air. And then you provide 100% oxygen. And then you remeasure pressures and resistance. If there was significant drop, then this is still reversible, and we can cautiously go ahead and close the shunt. On the other hand, if pressures does not differ and the resistance does not differ, then this is established pulmonary vascular disease. This patient has an Eisenmenger syndrome, and he should not have his shunt closed. These patients can get medical treatment. It is not very successful as yet, but this is much better than closing the shunt directly. So now we talk, what is a significant shunt? So now a patient comes to you by an echo report that there is a VSD. The patient is 6 months of age. A pediatrician was examining the patient because he had vomiting, and then he could hear a murmur. And then he asked the parents to do echo, and then the patient got a VSD which was 1.5 millimeters with left to right shunts. Would you expect that to be a significant shunt or not? This is important because patients with non-significant shunt have normal survival as the general population. We should not go ahead and start closing all shunts, because many shunts will close spontaneously or will be clinically insignificant so that they does not affect natural history. On the other hand, clinically significant shunt can be very serious and can lead to mortality or to irreversible increase in pulmonary vascular resistance, Eisenmenger syndrome. So it is important to define a clinically significant shunt. So we can define that by the presence or the lack of symptoms. X-ray changes, does the patient have plethora or not? Does the patient have cardiomegaly on X-ray or not? Signs of chamber enlargement, be that on clinical examination, on chest X-ray, on ECG, and on echo. Estimating high PA pressure either on echo or by cath. And obviously direct measuring of the ratio between pulmonary flow and systemic flow, QPQS, and finding that to be more than 1.5. QPQS can be measured by echo, but this is very, very inaccurate. So it is more reliably measured by either cardiac cath or MRI. So to have a clinically significant shunt, you can detect that by the presence of symptoms of increased pulmonary flow, X-ray change, chamber enlargement, high PA pressure, high QPQS. So in summary, we've talked about the systemic and pulmonary circulations. And we have agreed that in normal persons, systemic and pulmonary circulations flow in series. We've talked about flow, pressure, resistance, and compliance. We've talked a lot about left to right shunts, mainly ASD, VSD, and PDA. Talked about how the blood flows and the resulting chamber enlargement. Talked about restrictive versus unrestricted shunting, and that unrestricted shunting is a large shunt that equalizes pressures. Talked about Eisenmenger syndrome and how to identify that and stress that we should prevent it happening. And talked about what constitutes a significant left to right shunt. Thank you very much.
Thank you so much, Dr. Hatem, for an illustrative heavy meal about the pathophysiology. Actually, I would like to stress on a very important point you mentioned about Eisenmenger syndrome. It is preventable and also predictable. As you mentioned, we usually see a change in the clinical picture, in the chest X-ray and ECG findings. And here again comes the role of the basic tools like ECG and chest X-ray, as Dr. Hatem mentioned in his presentation. Thank you so much again. And actually, we have a lot of questions from our audience. You have a question from Dr. Iman Ali.
Thank you, Khaled. Thank you, and thank you for helping us, and thank you, Sarah.
Thank you so much.
You're welcome.
Actually, we have a question from Dr. Iman Ali. She wants again the explanation of the systolic flow in ASD. Why the ASD shunting is mainly systolic from left to right.
ASD
flow is systolic flow.
So during in the ASD, flow can be systolic or diastolic. We just mentioned that during systole, the mitral and tricuspid valves are shut, and so the ventricular pressures are not reflected into the atria. While during diastole, both mitral and tricuspid valves are open, and so the ventricular pressures are reflected into the atria. So worse LV compliance will cause slightly higher LV end diastolic pressure, which gets reflected into higher left atrial pressure, which is the driving force for the left to right shunt. But on the other hand, the pressure difference in the atria is much less than the pressure difference, for example, in the VSD across the ventricles. So you can see across the cardiac cycle flow going from right to left, but essentially the net flow across the ASD is left to right, so that the pulmonary circulation will get more flow. And this is predominantly because that the LV compliance is worse than the RV compliance. So LV end diastolic pressure is higher than RV end diastolic pressure. So LA pressure is higher than RA pressure.
Okay, another question from Dr. Hatem Sulaiman. You mentioned in Eisenmenger syndrome that we see a change in the clinical picture from dyspnea to cyanosis and its implication on measuring the oxygen saturation. So his question is, can we depend on the oxygen method, and is its result dependable?
I'm sorry, I'm having a poor connection problem, so I cannot hear you well. Can you repeat that again?
So can I elaborate this question, Hatem? Thank you.
Yes, please.
Thank you for the lovely presentation.
Thank you. Thank you.
I was meaning the oxygen method in measuring the pulmonary artery resistance.
Yes.
Inside the cath lab. We know that there is some fallacies in measuring the pulmonary artery resistance using the 100% oxygen. So do you take any consideration while measuring it in elaborating the results you get from the 100% oxygen method, or it will be like the nitric oxide?
So without going into much details of the fixed method, so we're using oxygen as a marker. And then the important thing here is that the amount of oxygen uptaken from the lungs will be equal to the amount of oxygen the amount that is taken by the blood will be the same as the amount consumed by tissues, and so that you get the oxygen as the marker for that. But it should not affect using oxygen as the pulmonary vasodilator should not affect the fixed method. Maybe Khalid can explain that more. He's more experienced with that.
Sorry, Hatem, I didn't get you.
So Haitham was asking, do you think using 100% oxygen as the pulmonary vasodilator can affect the method of the fixed method to calculate resistance and QPQS? So I've just mentioned that regardless the amount of oxygen you're giving in the FI2, the amount of oxygen taken by the lungs, by the blood in the lungs, will be the same as the amount extracted in the tissues. So whatever amount you're giving is the same there, and since you equalize the oxygen content at both, then the calculations is valid regardless if you use 100% oxygen or nitric oxide.
Totally agree with you. And actually, the standard now in doing hemodynamics is using nitric oxide and adenosine, but unfortunately, they are not available here in Egypt. Second, most important issue about hemodynamics is that we have a lot of variables during doing the hemodynamics regarding the pressure, the fluctuations in pressure during doing the hemodynamics, mainly in systemic pressure, due to the anesthesia effect. We should ensure that we don't have metabolic acidosis while obtaining the pressures and saturations. This is a very important point. I think it's a very complicated procedure, even more complicated than interventions, and it's far beyond the scope of our presentation now.
Yeah.
Thank you very much, Dr. Hatem, for this brilliant presentation. I know that it was quite tough to summarize everything in
Thank you, sir.
And you did it very well. There is another question about oxygen and the measurement of resistance, pulmonary resistance. And I think it's nice. I will tell it to you. It's from Dr. Hamed Osman. He's asking, what's your opinion about assessing the QPQS by MRI on room air and repeating with 100% of oxygen?
So that is a very valid method. QPQS can be quite accurately measured by MRI.
Yeah.
So yes, if your question was just measuring QPQS, yes, go ahead and do that with MRI. That is very valid and has been validated with cath. The problem is that obviously it is less invasive. Sorry, Khalid, but MRI is good enough. So but the problem with MRI is that you cannot measure pressures, and so you cannot calculate resistance. So if the question was only flow, so if you want to get the shunt ratio, QPQS, yes, go ahead and do that with MRI. It is very accurate, less invasive, very well established and validated. But if you want also to see, to measure direct pressures and calculate actual resistance, this is the gold standard here is the cath.
Totally agree. And
so it depends on your question.
MRI is non-invasive, but we sometimes still need cardiac catheterization, as Dr. Haitham mentioned in his presentation, to measure the pressures, the saturations, and to calculate pulmonary vascular resistance.
Yes, I totally agree. I gave a very good explanation about it, and it's so important to repeat it at the end of this presentation. So thank you very much.
Do you have any more questions from the chat on the Zoom or on the YouTube you need to ask to Hatem?
No, I think we are finished, and I would like to thank Hatem so much for this having me.
Thank you, and thank you for bearing with me. It's such a relatively tough topic, but on the other hand, I hope this will make things much happier when you go through the rest of the course. I hope you enjoy the course, and thank you for watching. Thank you, and thank you for having me.
So now, actually, I enjoyed this session because I'm so proud to have Dr. Hatem and Dr. Haysam Suleiman, Khalid Shams, and Sarah on board with me. I learned a lot today. As you all know, I work complex intervention, left main CTOs, bifurcations, and stuff like this. For me, I've been a little bit far from congenital heart diseases, but I always enjoy understanding it because it's like mathematics. You need to work your brain.
Sorry, Zahran.
I know Hatem did
congenital is much more enjoyable.
Yes, I agree.
Yes, it is actually. It is enjoying on paper. Maybe not so much enjoying on the bank account, but it is enjoying to study paper, yes.
After this webinar, you will be a congenital cardiologist.
Yes.
Yes.
I think you need to think around about completing your career in
congenital heart diseases. Yes. So actually, to me, I enjoyed it so much. It was flowing so easily, guys. I know you did. Yeah. For everyone's watching us, to present this kind of high quality science, as you see, it's totally based upon teamwork. It's not sponsored by anyone. We're not biased by any industry or national society or whatever. We're just offering you pure science with the best in the field. The team is doing lots of rehearsals and studying. You can imagine that we need to prepare this session 2 weeks earlier. We need to meet several times. We need to solve all the technical details, do several trials for the live transmission. And then there are some people working on the YouTube. Thank you so much, Karim, Mahmoud, Abdurrahman, Gamal today. They are working on the YouTube to collect all the questions and convey them directly to the Zoom. Thanks to Haysam Suleiman. Thanks to Ahmed Saeed, who's streaming live on the YouTube from his own laptop. And he has 3 internet connections, by the way, 3 backup connections. So the internet connection in Egypt actually was turned off intermediately while we were working. All the landline DSLs stopped for 10 seconds, but we were still continuing live on YouTube because Ahmed has set 2 backup connections for this. It's not my success. It's not CEC success. This is a whole team success. The most important member of the team is the viewers, the attendees, every single person that joined us on YouTube, on Zoom, or watching us later, or subscribing to this channel. This is the real team. This is the one that we are addressing. We will accept all your suggestions to improve and further on, move on towards better. These sessions for the congenital heart diseases will be fixed on Saturdays, hopefully. Next Saturday will be Eid al-Fitr, which is the feast for all the Muslims that are fasting Ramadan all over the world. So probably next Saturday will be skipped. And then we will resume with the Saturday. It's going to be 30 May, I guess. I will post you with the date, the time, the speakers, and everything. It will be a very interesting webinar about the ASD, and as all the CEC webinars, it's going to be a case-based discussion. So you have 2 weeks to study this webinar so well, to study the approach by Dr. Haysam and to study the pathophysiology by Dr. Hatem. You have 2 weeks to know this very well by heart. It will be recorded in high definition and uploaded to the YouTube in a few seconds after we terminate this live. So you can review it at any time. And after that, we will start by a very interesting ASD case-based presentations. We will go through ASD, and then further on, we will go through all the congenital topics in a very easy, smooth, clinical-based way. You will not need any effort to put the data inside your brains because it will directly slip inside your brain whether you like it or not. Thank you so much, CEC board, Haitham Suleiman, Karim Mahmoud, Ahmed Saeed, Abdurrahman Gaman. Thanks so much the congenital heart disease at CEC team. Thanks so much the speakers today, Haitham and Haitham. Thanks so much moderators, Khalid, Shams, and Sarah. Thanks to all the attendees from all over the world. We are glad, happy, and proud to have the biggest team now. Thank you so much, and see you in the next session.
Actually,
Thank you so much.
I need to thank you all, the CEC co-founders. It would have been like this without your support. And I would like, on behalf of all the attendees, the speakers, and moderators, to say to you, happy birthday.
Thank you, Sarah. Thank you, Hatim. Thank you, everyone.
Thanks.